All right, what's up, free thinklings? Welcome to the Free Thinking broadcast. I'm Dr. Tim Stratton, and today I'm joined by another doctor. Now, that's nothing new. I'm typically surrounded by many people with doctoral degrees. However, this great cloud of doctoral witnesses in which I typically find myself surrounded are those usually in the fields of theology and philosophy. Well, today, I'm joined by someone who might be considered to be more of a useful doctor. This useful doctor is none other than Dr. Dan Eichenberger. So, welcome to the show, Dan.
Thanks, Tim. It's great to be back with you.
Well, Dr. Dan is an Indiana native with over 25 years of experience as a physician executive and a healthcare consultant. Now, Dan, am I right? You and your wife, Stephanie, have been married for over 36 years now. Is that right?
That's correct.
Now, I got to brag about your wife a little bit because she's got a master's degree from Biola University in Christian apologetics, just like I do. And Dan and Stephanie recently hosted me at their house when I spoke at the Reveal Apologetics Conference in their neck of the woods in southern Indiana and also in northern Kentucky. Is that right?
Correct.
The directions right? Yeah. So anyway, I think it's fair to say, Dan, that you and your wife you guys are the best hosts ever. Absolutely love staying at your place and hanging out with you guys. In fact, here's a funny story. When I was staying at their house, I cut my head shaving. Now, I usually cut my scalp once or twice a year when I'm shaving my head. No big deal. It usually stop the bleeding fairly quickly. I'm used to it. Like, it doesn't happen a lot. But this one was much worse than normal because when I cut my head at the Eichenbergers, it would not stop bleeding. And I had a lecture to give, I think probably in the next 60 minutes or so. I had to be there giving a lecture, and my head was bleeding. It wasn't a massive head wound. It was a minimal head wound, but it seemed massive because it just wouldn't stop bleeding. And I had to get to the campus. Well, fortunately, there was a doctor in the house. Well, he happened to live there, and he was able to stop the bleeding and get me to the university on time. So thank you again for that, Dan. But with that said, Dan, he's not only a useful doctor, but he's also quite the apologist. Along with his wife, Stephanie, they make a great team when it comes to apologetics-related issues. But Dan, please tell us a little bit more about yourself. And more importantly, we're going to be talking about the coronavirus today. Tell people why they should listen to you and why they should care about what you have to say regarding the coronavirus.
Sure. Thanks, Tim. So my career started 30 years ago when I finished medical school, and I've been in private practice for the last 30 years, and I just retired from private practice in my administrative roles in December. So I have been a private practitioner. I'm boarded in internal medicine as well as pediatrics. I've seen adult patients, pediatric patients, birth to death, inpatients and outpatients, and I've done that in my entire career. So I've also been the chief medical officer of our hospital as well as the CEO for the last 5 years until I stepped down in December. Since December, I've volunteered at another hospital in Indiana as a hospitalist. So I've spent more than 100 hours just in the last few weeks taking care of inpatients, coronavirus patients who get admitted to the hospital. And I'm now currently doing some consulting work up in Michigan at a hospital and dealing with the coronavirus issues here as well, helping them and helping with some leadership and some medical group issues up here. So I've got a lot of experience. I've taken care of patients firsthand. I do live with my wife, and we have her 80-year-old father who lives with us as well. So between elderly in the home and multiple grandkids, I have all the normal concerns that most everyday people dealing with coronavirus have, and can speak to that from a personal perspective.
Well, needless to say, you've been around the block a few times and you got some good experience. Now, as a non-useful doctor, my PhD is in theology, and I take a philosophical approach to theological issues. But when it comes to things like the coronavirus, I'm a non-useful doctor. So I've got to make it clear that, I'm no expert when it comes to the coronavirus. I'm no expert regarding how we should fight this, what's been called the invisible enemy. Yeah, sure, I've got my opinions, but the PhD that follows my last name does not provide me expertise to address these COVID-19 issues. As I've said, you might as well ask a plumber what they think. Nothing against plumbers, but they've got expertise when it comes to the pipes underneath my sink. They don't have expertise regarding the coronavirus, but they're free to have intelligent opinions, but they just don't have expertise in that area. And this is similar to what I like to say about science and God, or scientists and theological issues. The PhD that follows the scientist's last name provides zero authority for them to address the existence of God or not with expertise. Again, you might as well ask a plumber what they think. A scientist studies nature, and God, by definition, is the creator of all nature. So, by definition, the scientist is simply in the wrong field to talk about the existence of God with expertise or authority. It's just they're in the wrong field. Not that they can't have thoughtful opinions on these things, but that their PhD doesn't give them expertise to talk about if God exists or not, or if anything other than nature exists, because their job is simply to deal with nature. So I'm just being consistent and noting that I don't have expertise on this particular issue. But be that as it may, Dr. Dan, you do have expertise on this issue. In fact, as you noted, you've successfully treated at least one patient with the coronavirus. So when someone successfully treats patients with the coronavirus, then that person has my attention. Now, sure, it doesn't make you right with everything you're about to tell us today. It doesn't make you right necessarily. But I'll tell you what, given your experience, I'm going to listen to what you've got to say about it. So with that said, I'm paying attention. And I'm also paying attention and trying to think logically about all the data that the media is feeding to me on a daily basis. And I got to say, I've got my reservations about the media. So I'm trying my best to read between the lines, when I watch CNN or MSNBC or Fox News or anybody else. So Dan, with all that said, let's cut to the chase. You recently published an article on the Free Thinking Ministries website entitled The COVID-19 War. Great title, by the way. So here's my question. First question, what sparked your desire to write this article? What was the catalyst behind it?
So the catalyst was basically the media's viewpoint of this, and always touting that we're in a war, and the president has done the same thing. So I wanted to correlate, if we're really treating this like a war, are we really treating it like a war? I mean, that's the issue. If we're going to call it a war, then our response should be warlike. And I wanted to point out in the article that from the beginning, basically to where we're at now, we're really not treating this like a typical war. And I agree, it's not a typical war per se, but the strategies to deal with that should be similar. And we've not done that, and that's gotten us to the point we are now.
Yeah, well, let me read the first paragraph of your article and kind of launch us in the rest of our discussion here. You said, the United States incurred an unprovoked attack, and the enemy, COVID-19, has inflicted casualties. The president declared war and already invoked the Defense Production Act, essentially forcing private companies into production of what the government demands. Since war has been declared, the expectation is there will be casualties, both of those on the front lines and the innocent. No realistic individual can believe wars come without lives lost. Yet the war strategy is marred with ill-defined goals and no clearly defined endgame. The strategists of this war appear to be politicians and scientists and actuaries. The president declared war. However, he is not relying on the general principles of warfare necessary to win. Wars are never won by near complete withdrawal and a shutdown of a country's economy, limiting the financial strength to continue the fight. History confirms that withdrawal comes with consequences, usually in favor of the victor. End quote. So, Dan, how do we win this war? How do we defeat this invisible enemy?
So there's a couple strategies. Number one, you have to have a clear defined endpoint. And the problem we've seen through the last couple of months is we went into this with the endpoint being flattening the curve.
Mm-hmm.
So we have been successful, and we were successful within the first 2 weeks of that endpoint. The problem is that for whatever reason, whether it's political or otherwise, the endpoint then got changed to preventing loss of life and all loss of life. And then the issue has been, well, we can't stop the war until we have a vaccine, or we can't stop the war until we have an effective treatment, or we can't stop the war until, the infectivity rate is a certain number. But that's not what we went into the war as the endpoint. So, why did the endpoint change? Who changed the rules? And so now what's the endpoint look like? And what's the consequences of changing the rules? So
the goalposts seem to have been changed or moved, huh?
Yes.
Yeah, okay. That's been frustrating. And I think the nation is feeling that frustration as well. Well, based on our current tactics and battle plan, or lack thereof, I don't know, do you perceive any positives with what we're doing? What are some positives and some of the negatives? What are some of the pros and cons to what we're doing right now?
Well, when we first entered this war, as we call it, the goal was to flatten the curve. And we had initially a 2-week period that we wanted to see what happened. We did exactly that. So we flattened the curve. We limited the impact to hospitals. We limited the impact to overwhelming healthcare systems in different areas. We early on they talked about we're not going to have enough hospital beds. We're not going to have enough ventilators. We're not going to have enough staff. We completely, by social distancing and closing things down, we eliminated that threat. That threat is gone, except for a few isolated areas that are still struggling. But we have maintained this complete shutdown everywhere. And this one-size-fits-all policy is just devastating. And the long-term consequences of what we're going to see from that is going to be far exceeding what we see now.
Yeah, it was kind of inspiring to see the nation band together to make sure that we flattened that curve and to make sure that the hospitals weren't overwhelmed. And I think we did kind of band together. I mean, people on both sides of the political aisle, even we seem to all say, "Hey, we're in this fight, we're in this war together," and I think we accomplished our mission. We won that battle, right? We flattened the curve. But like you said, now the goalposts have been moved on us, and now we're getting frustrated. So, in your opinion, what needs to change at this point?
Well, a couple of things. To go back just a little bit here, I've in my 30 years of practice and taking care of patients, I've always maintained that if you give patients and the families enough information, they will almost always make the right decision. And I feel that if we give the American people enough information that is correct and non-biased, they will make the right decisions on their own. And to impose, martial law-like behaviors from our government and taking away civil liberties is, and then having a media that is biased in their presentation of data and their graphs that they put on network TV, always making the graphs look the worst they can look, when they could have chosen other graphs that made the data look more reasonable or more statistically relevant, but they didn't. And they've intentionally made choices, number one, because we are in a 24/7 hour news cycle. We are in a 24/7 hour social media cycle. And that's the difference between today's pandemic and the pandemics we had back in the 1950s and 60s, which nobody talks about, which when you look at the numbers that correlated to those deaths, it's significantly higher than what we see in today's. If you look at the two numbers from those dates from the previous pandemics, we were talking 160 to 240 million Americans died from those pandemics. Yet we didn't shut the economy down. We're above 50,000 now with this one. But what's changed in the last 20 to 30 years? And I would say it's the 24/7 hour news cycle and the social media issues that we deal with.
Well, speaking of, in your article, you said, quote, the media portrays this war in a biased fashion, utilizing data and statistics, which support their narrative and underlying agendas, end quote. So you kind of touched on that, but as Greg Kokel would say, what do you mean by that?
Well, so if you just look at the last night, I can't remember which network news station I was watching, but they talked about United States now has more COVID numbers than any other country. Well, you know, that sounds bad. Yes, yeah. we have more cases now than any other country in the world. But what they failed to tell you is that on a per capita basis, we are still not the highest country in the world. And they could have chosen to put that in perspective of per 100,000 or per million population, but they didn't. They wanted to use the term, we have the highest in the world. CBS News got caught not once, but twice using a video clip or a picture from an Italy hospital, claiming it was a New York hospital, and then second time they used it, they claimed it was a Pennsylvania hospital. So, you can give them a mistake once using the wrong picture, but then to do it a second time, you have to wonder, what's really going on here?
Right. And also, fool me once, shame on you. Fool me twice. You get, why are you still watching?
Yes.
If you would, Dan, kind of sum up the rest of your article, the COVID-19 war, and what's the main takeaway that you hope people get from it?
Well, so the main takeaway is, what you're hearing from the mainstream media is a biased and skewed viewpoint. When you look at the more data we're seeing coming out of all countries, not just the United States, but all countries, the infectivity rate is high. We all agree that the infectivity rate of coronavirus is high. The death rate is significantly going to be lower than what we're currently touting in all the news media cycles. If you look at so New York State, they took 2 hospitals and they tested every pregnant woman that came through those 2 hospitals. And so they ended up testing 215 pregnant women. And of those 215 pregnant women, 33 tested positive. 4 of them had symptoms when they entered the hospital, and those 4 were positive. But the other 29 were completely asymptomatic,
really,
and tested positive. So if you look at the second study New York did, they did an antibody study, and that study showed that 13.9% of the patients they tested were positive for antibodies already, but had no symptoms. The Stanford study that came out a week ago Friday from the Santa Clara region, again, tested, this was and again, there's some what we call selection bias to this study because it was advertised basically on Facebook. So people self-volunteered to go in and get tested. So, some of them may have been wondering if they had it, may have been exposed. We don't know, but there's some bias to that. But when you look at what they found between 2.49 and 4.16% of patients they tested were positive for antibodies with no symptoms. That would correlate to somewhere between 50 to 85 more than what they had documented cases in Santa Clara County. Again, so that correlated to millions more people who have already been infected, already built antibodies, which means in order to build an antibody response on this test, it's a 2 to 3 week process. So these patients had to have been infected at least 2 to 3 weeks ago to have this antibody response. So the odds of this virus just starting in March is very, very unlikely. This has been around a long time. And I think if you talk to people, you will hear a lot of people say, well, I know this person who had a cough forever back in December and it just wouldn't go away. They tested negative for flu. They tested negative for strep. Some of those patients may have actually had the coronavirus. We just don't know. But to think that all these studies coming out are showing that the prevalence rate of who's infected already, it's significantly higher than what we are testing and have the positive results from. So how do we win the war? Herd immunity is really the term that we use. Now, we will never develop realistically herd immunity complete herd immunity to coronavirus, just like we will never develop complete herd immunity to influenza or RSV or a bunch of the other viruses that go around this time of year. Mm-hmm. But what we do know is the more people that get infected and build some sort of antibody response, there is some correlation that if you've been exposed to the influenza virus year after year after year, you typically have milder symptoms if you do get it in a particular year, because the antigenic strains of the viruses are similar each year. We're going to see the same thing with the antigenic strains in coronavirus. It's been around a long time. We've known about it. It's been in animals. My sister's a veterinarian. She's seen it in animals forever. So it's not something unknown to us. The difference between this coronavirus is it's the strains that are associated with the proteins are what we call novel. They're new to us as humans. And that's why it's more infective, and that's why we're having a little more difficult time. But our response has been way, way overdone on a global scale.
Well, it's interesting that you said that probably a lot of people had this back in December and leading up to March. In fact, when I was at your place, right after that, I went to Utah, and I was in Utah for a week. And while I was there in Utah, my wife got horribly sick. So I wasn't with her. She was back in Nebraska, and every time she was calling me, she was getting worse and worse and worse. She kept saying, "I'm dying," and her cough sounded horrible. And she was kind of joking at first, and she goes, "I think I've got the coronavirus." We weren't taking it that seriously back then. We were aware of it, but it wasn't really front and center at that point. And honestly, a couple of days before I was getting ready to come home, I was like, I don't know if I want to go home, because I think she does have the coronavirus. Anyway, she got better like the day before I got home. And, we kind of joked for a while that maybe, you probably had the coronavirus, but now we're thinking maybe you did. So is there a way to check and see if she did have it back then?
Sure. There's an antibody test that measures what we call IgM and IgG antibodies. IgM antibodies are what we call the acute antibodies that are present within a few days of developing the illness. And then your body gets rid of the IgM and transitions over to what we call IgG antibodies. And that's your long-term antibodies that basically that's what immunizations give us, is long-term antibodies to help prevent diseases like hepatitis B and some measles, mumps, rubella, and those types of things. We develop IgG antibodies. The problem with these respiratory viruses, whether it's corona or influenza or respiratory syncytial virus or parapneumovirus or all the other Coxsackie viruses, they typically have genetic strains and shifts every year. So develop an antibody complete that's going to protect you lifelong is probably unlikely. Even with mononucleosis, most people develop IgG antibodies and don't get mono a second time, but that's not 100%. There are people who get mono more than once. But these particular respiratory viruses, we will never probably develop complete herd immunity. But the more people that you can get exposed and building antibodies to that, the lesser chance our high-risk population is going to have a problem. And that's the issue. We want to prevent who we know are the patients that are going to have the highest risk. And right now, that's 65 and older. If you take away the age as the primary determinant of who gets sick, hospitalized, and on the ventilator, the second most common thing we've seen so far worldwide is obesity.
Really?
So if you're overweight, and especially if you're overweight and over 65, your risk is definitely higher. And then there's other risk factors with underlying diseases, heart disease, lung disease, asthma, all those other things contribute. But obesity is actually, after age, is the number one predictor for severe illness, hospitalization.
Really?
Yep.
Well, the quarantine isn't helping that out.
No.
We're gaining the quarantine 15, right?
and if you look at the worldwide data, the odds of having a major issue if you're under the age of 30 is extremely low. And infants and kids are extremely low. Less than 0.1% is going to have a problem. Although, if one single infant or child dies, you're going to hear it on the news 24/7 for at least, 72 hours about this one particular child. But but that's not what the data shows. But
well, and the flu would have the same kind of impact, right?
well, actually, the flu is more prevalent to cause serious illness and comorbidities in kids compared to adults. So influenza is probably worse on the younger population. So
but we don't shut the country down.
That's correct. That's correct.
So Sean Wilson just writes a question here in the comment section. He says, how reliable are the antibody tests that are used in these studies?
So that's a great question, and they are not 100%, as no test is, but the antibody test is pretty reliable depending on when in the disease you actually drew the blood. So if someone is symptomatic and it's within 24 to 72 hours of being sick, you're probably not going to get any antibodies, IgM or IgG. So early in the disease, you're not going to see an antibody response. And then if you test too early in the recovery phase, you're not going to see the IgG response. So the IgG response, really, you shouldn't be testing anyone for a minimum of 2 weeks after the onset of symptoms, and probably better at 3 weeks to test someone. So in between that, you can have false positives and false negatives.
Cool. Thanks for answering that question. I want to get into more questions. Before we do that, I just want to encourage those who are watching this, whether you're watching it live or watching it in the future, I encourage you to go to freethinkingministries.com and read Dr. Dan's article in its entirety. But as for now, let's go to some of the questions and the comments that followed the publication of your article last week. A guy named William, he asks, since you're talking about this COVID-19 war, he says, will the draft be reinstituted for this war? And I responded, I said, well, I don't know if a draft is needed when the war shows up on your doorstep. However, I'll pass this along to Dr. Dan. So how would you respond to that?
Sure. So I think that's an interesting viewpoint of a war, and he's right. So we have initiated a draft in some fashion. In fact, a lot of the state nursing organizations, my wife being a retired nurse, got a letter from the state organization asking if she'd be willing to come back to work and help out with the COVID crisis if need be. So she had a survey, ask about her underlying medical problems and, who in the house was with us and things like that, and whether or not she would be. So in some fashion, a lot of places have drafted, healthcare workers to come back. We've asked
voluntary draft.
Sure, voluntary draft. And again, I volunteered to go up and work in a hospital as a hospitalist to help out on open shifts. So,
well, we thank you for volunteering. Thank you for your service. Just as I would thank soldiers and those in the military for their service, definitely we need to thank you and everybody else in the medical field right now for what they're doing. Well, a good friend of mine, Dr. Dawn Simon, she's an evolutionary biologist at the University of Nebraska at Kearney. She's also a Christian. There's another story, an evolutionary biologist who's also a Christian. Great story there. We'll have her on the show sometime. But she asks this question. She says, how does he, talking about you, Dan, how does Dan define herd immunity? She says, I think it's generally defined as greater than 80% being immune, but varies on the specific disease. How long will it take to get there? How many people will die in the process? And she says, I'm ignoring the possibility that immunity is short-lived here, though that is certainly possible. She's got more to say, but let's just stick with that right now. How would you address Dr. Simon?
So she's correct that herd immunity is basically, for most diseases, somewhere in the 80% range. It can vary to a lower extent or higher depending on the infectivity rate. And we talk about that with what we call an N0 number, which is basically telling you about how an R0 level, telling you about the infectivity rate. So if you look at measles has an R0 coefficient of 18, which means for every one person with measles, the likelihood is they will infect 18 other people. Okay, that's a very high infectivity rate. Mm-hmm. When you look at influenza, normal influenza, the infectivity rate, the R0 level for that is typically, we think, 1.4 to 1.8. And then for coronavirus, initially, in the early stages, we thought it was going to be between 1.6 and 2.4. Some people now are saying it's going to be much lower, but we just don't know yet until we have a lot more data comes in. But so depending on the infectivity rate, right now we're thinking that to get herd immunity for coronavirus, it's probably in the 70% range to develop herd immunity. And again, the problem with coronavirus, as with all the respiratory viruses, is they go through what we call antigenic shifts and drifts, and they change their protein. So it's hard to get complete herd immunity because they're always changing. So, but the more immunity you get to at least different strains, the better your community is going to do overall.
All right. She goes on and asks, or she says, I agree with some of what Dan wrote here, but not the tone of it. I'm worried about the impact of economic consequences on people's livelihoods and mental health consequences for me personally. I'm frustrated that some people don't understand that, but I definitely do not agree that, quoting you now, we are held hostage by bureaucrats and activists who intend to utilize this crisis for their underlying agenda, end quote. She says, I think most people are doing the best they can. Now, she does say that, she says, of course, I don't expect him to have all the answers, partly because no one has them in this specific instance. Just wondering what he thinks. So it was nice of her to clarify that. But how would you address what she said about your tone?
So to be upfront, my tone is biased. I don't.
No, you're bias free, aren't you?
So I will admit that my tone is on the side that we have, overreacted to this issue, and we have done that, as our friend Frank Turek says. Science says nothing; scientists do. So we all have the same data that we are looking at, and we had the same data from the beginning, and we have the same data that is now forthcoming and continues to be given to us to look at. But how we're responding to that data as, quote, scientists, and how we're making public policy is significantly different. And so there are untoward consequences that we are going to see. In fact, there was a study they just had on the news yesterday that we are looking at a minimum of 2,000 additional suicide deaths related to the economic issues just here in the United States. The British Journal of Medicine, back after the 2008 depression, showed that there was a minimum of 10,000 suicide deaths alone related to the economic depression. So when we look at patients, and I can tell you from personal experience, I've had a patient who his bypass surgery was put off because of the coronavirus issue. He ended up dying of a heart attack before he could have his bypass surgery. Wow. I've had a patient took care of that a normal procedure to take care of her lung issue would have been done in surgery. They put it off, and we had to send her home with a chest tube in her side, and she will be on antibiotics for 8 weeks with that chest tube in at home because we were unwilling to do the surgery that we would have done otherwise. So that morbidity is significant. We're going to, after the 2008 depression, we saw homelessness went up anywhere from 15 to 34%, depending on which state you looked at. And so you talk about food issues, healthcare issues. If a family has to choose between putting the food on the table for their kids or buying their medicine, guess which one they're going to choose. So we're seeing people delay elective procedures, which is going to pick up on some early diseases. We're going to see patients have delayed chemotherapy regimens because of this issue and die from the complications of those type of healthcare issues. In addition to that, worldwide, so the United States, as most people know, we provide healthcare services and healthcare benefits to multiple third world countries. And if our economy significantly declines, we're not going to have the resources to help prevent the deaths in those other countries that we normally do. So we're going to see worldwide a lot of deaths related to our economic decline here in the United States that people aren't counting. So when you look at a public policy or when you look at a war strategy, you don't go into a war saying, well, this private's going to be on the front line, so we can't go there and do that because he might die. I mean, we know there's going to be casualties, but you have to look at the big picture of what the entire consequence of your decision is when you're making public policy. And too many people in the media are focusing on an individual rather than a global policy. And that's not what public policy or public decision or wartime decisions are made from. And that's not good leadership.
Yeah, well said. Brandon Moore asks a question here in the comments. He says, the video of two doctors, similar opinion, from Bakersfield were booted from YouTube. Do you know what he's talking about?
I don't know. I haven't seen that.
You don't either? He says, do you have a backup so we can share? I guess share this video. That's what I don't know what the video is that Brandon's talking about here.
So again, that brings up an interesting point about what coronavirus has done to our freedom of speech.
Yeah.
I mean, this is just another issue where there are certain media outlets that have almost complete control of the content and what is allowed to be published and what isn't. And the agenda behind that is significant. This is just a perfect example of that. I mean, why are we not allowed to see that? I mean, if we have two dissenting opinions, what's the problem with giving that information to the American people and letting them make a decision?
Well, we'll see what happens to this video.
Yeah.
Hopefully it stays up. Let's go to another question from a really good friend of mine. Her name is Melissa Presser. And she said, after reading your article, is Dan suggesting that people voluntarily agree to be exposed and hopefully recover to create herd immunity? If so, is he volunteering? Hey, that's a good question. How would you respond to Melissa?
So first off, yes, I have volunteered to be exposed. Yes, I've taken care of a number of coronavirus patients personally, admitted them from the emergency room, taking care of them on the floors, taking care of them in the ICU. And I did that voluntarily when I was asked to fill in some open shifts at a hospital. I have an elderly 80-year-old father-in-law living with us at home. I have grandkids who still come over to visit. So yes, I've been exposed, and no, I'm not fearful. I take appropriate precautions. But am I asking people to voluntarily be exposed? No, I'm asking people to make an informed decision based on the available information to make a decision for themselves, putting a risk-benefit ratio in place that is good for them, and make their own personal decision. This is a free choice decision, a free will decision.
You know, since you said that, I have to show people my shirt. Coronavirus, my body, my choice. Now, he said it's a free will decision. Actually, I like to wear this just as a conversation starter to get us talking about pro-life issues and abortion issues. But I think you're right. It is a free will decision, and you're asking people to make informed decisions and to take appropriate precautions. Now, you've been you willingly been exposed, but you've also worn the masks and the gloves and everything like that. But would you say, what would you say to somebody who said, well, you're not really willing to be exposed if you're wearing the mask and the protective gear?
So I don't think anyone should be willingly exposed to anything that's harmful, whether it's, excessive alcohol, whether it's drugs, whether it's whatever it may be. Driving 100 miles an hour is not a willful thing to do with the known information we have. So I don't think people should take irrational choices about it. But if you're sick, you shouldn't go out. If you're going to be around a group of people that's 50 plus and you're going to be in close contact, you need to consider whether or not you want to do that at this point. And if you have underlying medical conditions, you certainly need to be considering those types of choices. But it should be your choice based on the available information. So if you want to take that risk, it's completely up to you.
Well, she continues. Let's see. Melissa says, again, I got to say, Melissa's a close friend. She's brilliant. She's a great apologist herself. But she says, personally, I would like to avoid having people exposed en masse until they have come up with an effective treatment that appears to work in the vast majority of cases. We don't have that yet, but that could come well before a vaccine. And she says, oh, you have polio? Well, here's how we treat that. Oh, you have tuberculosis? Here's how we treat that. Oh, you have COVID-19? We just aren't sure about what to do for that yet. And she says, I think that day will come, but we're just not there yet. And she says, when the peak has passed, when the first wave is gone, when a common treatment has been found, then I will feel more comfortable with my asthmatic lungs being exposed, because doctors will absolutely know what to do and survival rates for all will increase. But should I contract this and risk dying right now? No. There is far more for me to consider right now than simply my own life. So how would you address my good friend Melissa again in that with her points there?
Sure. So I understand Melissa's point of view. She has an underlying condition, and she is concerned that if she would be a higher risk patient if she got the disease. That is correct. But it is an irrational fear to think that you have to shut down an economy and a complete population and society waiting on something that we know is not going to occur. We are not going to have, we don't have effective treatments for any viruses per se, other than vaccines long term. And so we are not going to have an effective treatment for every coronavirus patient that comes through our doors anytime in the near future. So if you're going to wait on that, I'm not sure how you're going to live and support yourself if you're going to wait on that, because that's not going to happen. We are well 12 to 18 months at minimum for a vaccine that's going to be effective. And as far as antibiotic or antiviral treatments, we're still testing some. But again, we test those in a lot of viruses, and we don't have effective treatments for even influenza. We don't have effective treatment. We have supportive treatment. We have drugs that help minimize the symptoms and the difficulties with the disease, but we don't have a drug that eliminates influenza. So if she's waiting on an effective treatment, she's going to be waiting a very, very long time.
And if the economy should stay closed for that very long time, then it's a guarantee that we'll crash. And not only will Americans suffer, but so will the rest of the world that we serve.
Absolutely. Right? Absolutely. And that will happen long before 18 months.
Okay. What do you think that number is?
Well, if we don't get the economy back up and running to some degree fairly quickly, we're going to see a lot more deaths related to the economic issue than we are the coronavirus issue.
Well, she finishes by saying, as one of those people, she says, with an underlying condition, every time I hear someone say, it's time now to open up. Sure, some people are going to die, but most of us won't. She says, that's like a slap. Knowing that, a slap in the face. She says, knowing that I'm one more likely to have complications than most, it's as if my life isn't as valuable as someone else's. And she says, I know that's not the intent, but that's what it feels like. And I've got to say, before I turn it over to you, Dan, I can relate, or at least I should say I'm trying to relate. And, if those at risk of dying or having complications due to COVID-19 were those who have previously had their appendix removed, then I'd probably feel the same way, since I had my appendix taken out in the 90s. So I've also got to say that I'm kind of torn. I want to get people back to work. If people aren't working, then I'm not going to be able to do ministry very long. I'm not going to be able to continue to do free thinking ministries. And then I won't be able to provide for my wife and my son, because free thinking ministries is supported by people who are out there making money. It's that trickle down economics. It's totally true when it comes to ministries. But so I want people to get back to work. I want people to provide for their families. And after all, why should Walmart employees right now be able to provide for their families, but not those who own other non-essential businesses or who are employed by these non-essential businesses? I want to get our country back on its feet, but then I want to protect people. I think about my parents. I love my parents. They're in their 70s now. I'm fine with them being quarantined at home. I miss them. I haven't seen my parents since March 9th. They only live a half hour from me. And I haven't seen them for a long time. Well, I guess I should say I pulled up into their driveway once and honked the horn. They came out on the porch, and I waved to them and said, "Hey, Mom and Dad, love you guys." But I didn't get close to them. And I really miss them. But you know what? I'm fine for right now with them being quarantined. I don't think they should be out in the public square, but I also think that we should open up our society and our economy and get things moving again, but still take precautions. I don't know. I feel like we're caught on the horns of a false dilemma here, Dan. I mean, is this an either or can it be a both and? And is there a way to fight this war and win this war, all while taking care of those who are more at risk? How would you answer that?
Well, I do believe we are being given a false dichotomy. It's not just an either or approach. It is an and approach. We can reopen the economy in a smart fashion, in a safe fashion, taking precautions and protecting those most vulnerable. And the most vulnerable are those elderly, over the age of 65, those with underlying medical conditions, those that are obese, and those in certain races seems to be attacked more with this virus. Now we're still trying to figure that out, but why that is, whether it's socially economic issues or otherwise. But so there is a way to do this. But again, when you're making public policy decisions, you cannot base it on an individual. You have to make public policy decisions on a population-based mechanism. So I understand Melissa's point that she may feel like she's being targeted as an individual. But when you're a government or when you're a huge institution or a corporation, you don't make decisions based on a single employee. You make decisions based on what is the best for the corporation and the majority of the people that you are working with and for. So when we're making public policy decisions or war decisions, like I mentioned earlier, you can't look at a single private on the front line and think that if we do this, he might die. Yes, he might. That's part of war. That's part of this war strategy. But if you want to win the war, you have to accept those types of risks.
I think of my friend Tito Santiago. He is a warrior he's got several underlying health conditions, but he would agree with you. He's like, he affirms that he is a warrior himself and he's willing to take that risk because for the good of our neighbors, we must open up our society, our economy, and get back to normal as possible. Anyway, and he said, "Hey, I'm one who has several underlying health conditions. I'm one who is at risk here, and I'm willing to take that risk." He's willing to fight for his neighbors, and I know Melissa is too. She loves her neighbor just as she loves herself. I know that that's true about her. She's a fantastic person. But like I said, I can totally see her point. And like I said, if it was, hey, if you got your appendix out, you're going to be more at risk, I would have these reservations as well. But I think you make some great points, and how we got to see the bigger picture here. You know what? We've got some other questions coming in here. Neil, he asks, when we hear things like hydroxychloroquine mixed with zinc has shown great strides so far with doctors, and the media doesn't like to cover it, it seems many in the media don't want to find a cure. And then he says, what do you think of hydroxychloroquine/zinc combinations or other things being put out there, such as UV light treatments?
So it's a great point, and I can tell you personally, the patient I had in the ICU, we did give hydroxychloroquine and azithromycin, the Z-Pak, and zinc to that patient. She did come off the ventilator. She did go home. And so we have seen positive results. Now, I know the media touted the VA study that came out just last week that showed increased morbidity and mortality on those patients who got hydroxychloroquine. But, number one, this wasn't peer reviewed yet. And now that it's being peer reviewed, you're seeing that the patients that were selected to receive hydroxychloroquine were already very end stage patients. I mean, this was a last ditch effort to patients already on the ventilator, elderly, multiple comorbidities. They did not give it with the same combination of the other drugs. So there's a lot of issues related to that result that came out of that VA study. But why did the media tout that VA study when they won't publish some of the positive results that you're seeing from chloroquine and some of the positive comments you're seeing from doctors who are using it first line? There is an underlying narrative from the mainstream media, and this coronavirus has not only been politicized, it's been weaponized. And, I've said before, there is media terrorism, and the media has used terrorism methods and methodology to put fear into the American people and to lead them down a path that is not healthy.
So you're saying that hydroxychloroquine works?
I'm saying we have seen positive results in patients. Now, is it a complete cure? No, but it's another part of our arsenal that does seem to be beneficial in a group of patients. And without doubt, if I had coronavirus or if my family member had coronavirus and was going to end up on a ventilator, would they get hydroxychloroquine? In a heartbeat.
Really?
Yes.
That's quite the endorsement.
And I would bet you that anyone who is a naysayer, if they were put in the situation and you had to ask them, well, we can give you hydroxychloroquine and try and see if you get better, or we can not give you anything. We'll see how many people would actually take you up on the offer.
Good point. Neil just wrote back in and said the real war is an information war. Do you think that's right?
I 100% agree.
Well, Dr. Dan and Neil Dutenhofer, maybe you are cut out of the same cloth. Yeah. And Tony Vance writes in and he says, free thinking warriors. That's right. We are the free thinking theists and the libertarian freedom fighters. And that's why we're called Free Thinking Ministries. So let's see. Let's get back to some of the other questions that I had ready to go here. Yeah, there's some of these questions that have been keeping me up at night recently. And you mentioned this earlier, but it seemed to me that the original intent of the quarantine was to flatten that curve. But now it seems that people aren't really talking about that curve anymore. We saw all those graphics and images of that spike, and then saying we got to flatten it. Maybe it's just me, but it doesn't seem to me that I'm seeing that as much. In fact, Mike Austin, who's a great philosopher, he's in your neck of the woods, actually, in Kentucky. You're in southern Indiana. Uh-huh. But Mike asked some great questions yesterday. And I've got to preface that Mike and I are friends. We share much of the same theology, but we often disagree about how theology should play out politically. He leans more left, he's more liberal, and I lean more right, I'm more conservative. So we have some great debates, some great arguments, sometimes heated arguments as friends. And then, if we cross the line, we'll apologize and hug it out, but that's what philosophers do. But this whole thing, we seem to be finding some common ground on this, where we normally might not see eye to eye, maybe. So anyway, let me phrase this. I think Mike did a great job of asking 3 questions. So let me throw these out to you. He says, number 1, is the point what we were originally told, to flatten the curve, or is it to prevent as many people as possible from contracting COVID-19 until we have a vaccine and or treatment, as some now think? So we did address this already. We talked about how the goalposts moved. Would you want to say anything more to that?
No, he's correct. I mean, the original plan and the original endpoint was to flatten the curve to prevent an overwhelming of our healthcare system. We did that very well within the first couple of weeks, other than a couple of key areas, New York City. But again, in my article, I specifically said this has always been a logistics issue, we have the resources. We just don't have the resources in the right place at the right time with the right amount. That's the issue with this. And a one-size-fits-all approach to fighting it was absolutely the wrong way to go, in my opinion.
Well, as a non-useful doctor, I share the same opinion. Okay. His second question is, why is it okay for big box stores like Walmart and Lowe's to be open, but not local small businesses? He says, I've seen full parking lots at these places in Richmond, Kentucky, while small business owners are forced to keep their doors shut. Seems like the opposite would be safer. What say you, Dr. Dan?
Well, he's exactly right. Smaller is better. Fewer people in an area is better. From what we know from coronavirus, all the studies have shown that it is a close contact disease as far as the spread goes. More than 80%, it is a very close contact. You see it in nursing homes, you see it in families. You do not see patients who are out jogging and out on the beaches getting coronavirus. That is not how this is spread. And therefore, the more people you put in a place like a Walmart or a Kmart or any of the other big box stores, your incidence of spread is higher there than it would be in the small box places with fewer people. So he is correct. The problem I have from a libertarian viewpoint is that this is not government's role to pick winners and losers, and that's what we're seeing happen here. The government is deciding what's essential and what isn't essential, and that should never be the case. It was never the role of government to do that. And anytime you get the government choosing sides, you're going to have winners and losers that the government or media or someone else wants to have happen. And there's underlying motivations why some of those decisions are made, in my opinion.
So you would affirm coronavirus, my body, my choice.
100%.
All right, freedom. All right. His third question. Mike says, what about those who are deeply suffering because of the lockdown in a variety of ways? People who have undiagnosed cancer, etc., those struggling with mental illness, the day laborer wondering how to get food, and all the other suffering the lockdown imposes. And then he adds, I don't have the answers, but essential human goods are at stake. And if we think that we can do this for 12 to 18 months minimum, even with some amount of opening things up, he says, I'm skeptical. We need vastly increased testing and tracking capacities, but we also need to make decisions based on all of the relevant human goods at stake. What would you say to that?
Well, I completely agree with him. Other than, I'm not sure how much, people rely on the testing, I think, more than they should. We deal with this in the hospital setting all the time. If we have asymptomatic employees who want to be tested, there are risks and benefits to testing them. Number one, why would we test them if they're asymptomatic? If you test them today, the result's not going to be back for 24 to 48 hours. What happens? What if they were exposed tomorrow?
Right.
So it gives you a false sense of security. So testing is one of these things that a lot of people feel good about. If you have an EKG in your doctor's office and he tells you it's normal, that might be reassuring, but as a physician, it's really not reassuring. I'd rather see an abnormal EKG because that actually tells me something. A normal EKG we expect to see. That doesn't necessarily mean that you're not going to walk out and have a heart attack 10 minutes from now. So testing is a false sense of security that too many people are relying on. We need to use some common sense. We know that there is a lot of consequences of economic depression. I was sitting on a meeting 2 weeks ago with the Indiana State Medical Association, and our chairman is a psychiatrist, and he said, the 8 patients he admitted that day were all depression patients, suicidal patients related to the economic issues. So we're going to continue to see more and more problems by the shutdown. And he made a comment, it can't go for another month or so. I don't think we can go for another 2 weeks without opening things up. I don't think we can go another week without starting to open things up and getting the economy back up and running, or we're going to see some really negative impact to our communities.
Yeah, I agree. There's been one thing that I've enjoyed during this quarantine time. My son just turned 18 last week, and I'm getting to spend so much extra time with him right now. I mean, how many parents get to spend all of this extra time with their 18-year-old?
So the question is, would he say the same thing?
Probably not all the time, but he's also, he's doing online classes. He's finishing up his junior year right now. Man, I tell you what, he's going to be a senior next year, and I sure hope he gets to have a wrestling season next year. He's worked so hard for this final year of wrestling, and I sure hope he gets to compete. But he's working as a pizza delivery guy right now, and he's working in the kitchen and as a delivery guy. And so he's out and about, and then he comes back home, and so it's kind of like, I think my wife, she might have had it. If not, Ethan's out. He's risking exposure. I work from home most of the time. So, I was social distancing before it was cool. But I'm glad that at least Ethan's got a regular paycheck right now because he's delivering pizzas. But why is it that, pizza delivery places can support their families? Ethan might have to start supporting me. But why is it that these certain places are allowed to support their families or to make money? But hey, if you're non-essential, too bad for you. Go starve to death. Just doesn't seem right to me. But hey, with all that said, I'm enjoying the extra time with my wife and my son.
Which is interesting because there is a contrapoint to that, and that is I have a friend who's in the police department. The domestic abuse and violence calls that the police departments have taken have skyrocketed since this. The alcohol recidivism and the drug use recidivism, when you shut down the AA meetings and the NA meetings and they're not able to get together and talk, I mean, that's what saves some of these alcoholics from going back to drinking is the meetings. And when you eliminate that, we're seeing a tremendous, 54% increase in alcohol consumption. The last report I saw, 34% increase in anti-anxiety medicine prescriptions since the shutdown has taken place. So, there are consequences that some of your listeners and readers don't really think about because, I mean, again, a lot of your readers probably are in stable homes and,
have good relationships with their family.
Correct, like you. But not everybody has that. So child abuse issues have gone up. It's a tremendous impact that some of us don't understand or appreciate what our colleagues and our friends and our people in our community sometimes live with.
Oh yeah, I mean, just think about the children out there who do have abusive parents. They probably hate this quarantine more than anybody else right now.
Yes.
Well, the last thing, maybe the last question that I have is, if everybody is staying at home all the time, washing their hands more than ever before, doesn't it seem like we're kind of, that we wouldn't be exposed to things that we need to be exposed to? I'm not talking about just the coronavirus right now. I'm talking about all kinds of things. Don't we develop immunities by being exposed to all different kinds of things? But right now, we're not just avoiding coronavirus. We're avoiding, it seems to me, everything. And I mean, it's good that we're washing our hands. I've never washed my hands so much in my life. I think my hands are starting to get used to it now. But for a while, I felt like the skin was going to fall off because they were getting so dry. But we're washing our hands so much. We're social distancing. We're not being exposed. Is there a danger there? I mean, what happens once they say, okay, quarantine's over, go back out into the public? Isn't that kind of dangerous?
In some regard, it is. And one of the unintended consequences of what this shutdown has done to hospitals, per se, is when you social distance and you isolate and you quarantine all the people we did, we have eliminated not only the coronavirus issue, but all the other respiratory viruses that we normally see this time of year and have multiple admissions for this time of year have nearly completely gone away. So I just looked at the data in the Michigan hospitals. More than 70% of the hospitals in Michigan, their average daily census is under the 50% mark. So in other words, they have less than 50% of their beds occupied because no one is coming in, not only for elective cases, but for the normal illnesses and the normal respiratory cases we would see this time of year. This social distancing and quarantine has eliminated all of them. So we've got hospitals who are going to have to file bankruptcy. We're going to have small hospital, critical access hospitals shut down because the impact financially on them has been devastating with this shutdown. So
you're saying some hospitals are going to shut down permanently?
Yes.
So then moving forward, we get past COVID-19.
Yep.
And now we don't have hospitals.
And now you have less access to care than you had before, and it's a problem. So that's another unintended consequence of the economic shutdown that people don't appreciate and don't realize. I mean, so all the hospitals that I'm associated with and I've contacted, every hospital has either furloughed, laid off, workflow adjusted, taken cuts in administration's pay. Doctors have taken cuts in pay. Some doctors aren't taking any salaries. So this has been a huge financial impact on the healthcare system in a negative way, unattributed to direct coronavirus patients per se. So that is not appreciated and certainly not touted in the news that you'll see on a daily basis.
Well, tell me this. What can we do about it? I mean, do you suggest going out into the streets and protesting and rioting, or what do we do? I mean, what do we just sit around and complain on YouTube all day, or can we really make a difference? What do you suggest?
So as Christians, we need to, obey the law and follow our leaders unless it, is against God, basically. So, I mean, if there are laws in place, we need to follow those, but we do have rights to demonstrate and, have some social discourse that is healthy. I don't, an armed resurrection is not the answer here. Yeah. But the government can do a lot of things. Government can allow us to open back up and give us the information we need, let us make our decisions ourselves, not pick winners and losers. And the thing that the government can do is to limit the amount of attorneys that are able to sue. Because if you're an NBA or the NFL, do you want to be the first one to open back up and risk a patient getting coronavirus and being sued by a lawyer? No, we need to limit the litigation aspects in our society related to this so that companies can feel comfortable reopening in a safe manner.
So we should, you're telling us that we should encourage, I mean, what can the average person out there do? They're watching this right now and they're saying, I want to make a difference. What would you tell them to do?
Well, based on the state they're living in, follow the legal issues that they have in their state. But yes, getting back to a routine, normal lifestyle, whatever that means for them, understanding nothing is risk-free. Getting out of bed in the morning is not risk-free. In fact, the statistics nationally in the United States, 100 people every single day of the year die from an accidental fall. 110 people every single day in the United States dies in a motor vehicle accident. And every single day of the year in the United States, 170 people die from an overdose. So nothing is risk-free in our society. We need to balance the weight of information and make a decision ourselves and get our liberties back.
Mm-hmm. There's one theologian out there. I disagree with him on so many things. He's a Calvinist and I am not. Name's John Piper, well-known guy. But he wrote a book. I can't remember what it was called. But one of the chapters in the book, it was called, I think, To Risk is Right. And I think the book was called Don't Waste Your Life. I'm not sure on that. But yeah, he said to risk is right. And, if I wouldn't have read that book, I would have never asked my wife, well, who was not my wife at the time, I would have never asked her on a first date. Because that's the one thing it gets right. It is good to take risks, especially as Christians. We know that God is ultimately sovereign, and we can trust him. And so with that knowledge, we can take godly risks, rational risks. You're not asking us to do irrational things, but to count the cost. to be aware of the danger, and to act appropriately. So I think that's well stated. Let's take some risks, take rational risks, and let's try to honor God with them. Let's don't be stupid, but let's take some rational risks. Well, Dan, is there anything else that you'd like to say before we sign off?
Well, as Christians, just remember that we are not in ultimate control. We are not human bodies with a soul. We are heavenly souls with a human body, and we may, this is only a location for us. Our ultimate location will be elsewhere. So this is only temporary.
Well said. I guess you and I are cut out of the same cloth as well. Like I said, that, hey, you don't have a soul, you are a soul who has a body. Yeah. And thankfully, these bodies, we will experience all kinds of sickness, we'll experience all kinds of pain, evil, and suffering. Thankfully, one day we will have a new body, and we can thank Jesus for that. But I want to thank you for being on the Free Thinking Show. And for those of you that are watching in the future, feel free to continue to comment on this video, and I'll pay attention. And if you bring up some good questions that you'd like Dan to address, I'll let him know about them, and maybe he'll come back on in the comment section and answer your questions. Other than that, I want to encourage you, if you have not yet subscribed to the Free Thinking Ministries YouTube channel, please do that and stay tuned for weekly videos and more live streams as well. So thanks for hanging with us for over the last hour. And Dan, thank you so much. And I'd love to have you back sometime soon.
Be happy to. Thanks, Tim.
All right. Thank you.